Distinguished colleagues, welcome. Today we're diving into a focused clinical briefing on what is arguably one of the most significant parasitic diseases affecting the human nervous system. It's a major cause of adult-onset seizures across the globe. We're going to break down neurocysticercosis, zeroing in on the critical insights you need for diagnosis and management. We've structured this explainer into 6 parts to give you a clear clinical pathway. We'll start with the parasite and the disease itself. Then we'll walk through diagnosis, the standard treatment for adults, some important considerations for pediatrics and public health, key complications, and then we'll wrap it all up with a quick knowledge check. All right, let's jump right into section 1, the parasite and disease. It's fundamental to understand exactly what we're up against here. So at its very core, we're talking about cysticercosis. This is the condition caused when a person ingests the eggs of the tapeworm Taenia solium. Now, what's interesting is that these eggs don't grow into an adult tapeworm in the gut. Instead, they hatch into larvae that migrate and form these small encapsulated cysts pretty much anywhere in the body. And this is where we hit a fascinating clinical paradox. When the cysts end up in the central nervous system, what we call neurocysticercosis, the clinical presentation is dramatic. We're talking severe headaches, new-onset seizures. It's a major neurological event. But the person who actually has the adult tapeworm, the one shedding the eggs and spreading the disease, is often completely asymptomatic. This makes breaking that cycle of transmission an enormous public health challenge. So that brings us to section 2, diagnosis and pathogen identification. Now that we have a grasp on what it is, how do we actually go about finding it? Diagnosing this is absolutely not a single test affair. It's a multi-modal process. We, of course, start with a thorough anamnesis and clinical exam. Then we lean heavily on neuroimaging, CT or MRI, to actually visualize the cysts in the brain. Serology can be useful for detecting an immune response, but really the gold standard, the definitive proof, is molecular identification of parasite DNA taken directly from a cyst. Now here is a critical clinical pearl, something that can easily lead you down the wrong path. We're all trained to think parasites, eosinophilia. But in neurocysticercosis, the eosinophil count can be completely normal or only slightly elevated. Its predictive value is really quite limited, so you should never, ever use a normal count to rule out this diagnosis. Okay, once we've secured that diagnosis, we can move into section 3, the standard adult treatment protocol. The standard of care is essentially a 3-drug regimen. We hit the parasite hard with 2 antihelminthics, albendazole and praziquantel. But I want you to pay close attention to that 3rd drug, dexamethasone. It's not just an adjunct. For patient safety, it is arguably the most critical part of this whole protocol. And the sequence here is non-negotiable. It is absolutely crucial to start the corticosteroids 1 day before you start killing the parasites. Why? Well, as the cysticerci die, they release a flood of antigens, provoking a massive inflammatory response from the host. This steroid pretreatment is what suppresses that response and prevents the cure itself from causing dangerous cerebral edema or worsening seizures. Moving on to section 4, let's touch on some special considerations, particularly in pediatrics and public health. This is a hard and fast rule. Albendazole is absolutely contraindicated during pregnancy. And of course, when we're treating children, clinicians must refer to specialized pediatric formularies for precise weight-based dosing. Just a quick professional note here. While cysticercosis is a disease of significant public health concern, the specific mandated reporting requirements were not detailed in the clinical sources we used for this briefing. As always, clinicians must adhere to all local, state, and national reporting guidelines. So, what are the most severe consequences we're trying to manage and prevent? Section 5 gives us a quick look at the key neurological complications. When you boil it all down, the clinical presentation is really dominated by these 2 issues. The cysts act as space-occupying lesions, which can increase intracranial pressure and cause those persistent, often severe headaches. And most importantly, their presence irritates the brain parenchyma, disrupting normal electrical activity and triggering the frightening onset of new epileptic seizures. All right, let's put all this information into practice. For our final section, we have a quick clinical knowledge check. So let's consider this scenario. You have a patient who presents with new-onset seizures. They also have a history of travel to an endemic area. What parasitic infection should be very high on your differential, and what are its hallmark CNS symptoms? Sometimes studying these incredibly complex parasitic life cycles feels like you're peeling an onion. There are always more layers of complexity. But I suppose perhaps that's just a Taenia thought I had. The answer, of course, is neurocysticercosis, caused by the larval form of Taenia solium. And in a patient with that kind of history, new-onset seizures coupled with headaches are the absolute classic red flags for this infection in the central nervous system. Okay, second question. Can you recall the specific details of that standard adult treatment protocol? Be sure to include the vital adjunctive therapy that we discussed. Let's just pause here for a short lecture moment because this is so important. The corticosteroids are not treating the parasite. They are managing the patient. They work by mitigating the body's own powerful immune response to the dying cysts, which is essential to prevent the treatment itself from causing iatrogenic harm to the brain. And the full correct answer is the dual antihelminthic therapy of albendazole and praziquantel, always administered with that crucial pre-treatment of dexamethasone. And that brings us to our concluding thought. This is really the fundamental public health puzzle. Given that the human carriers who perpetuate this entire disease cycle are very often asymptomatic, what public health screening strategies could we possibly develop that would be effective enough to find and treat them, and finally break the cycle of transmission? It's really the key challenge in moving from just treating this disease to one day truly preventing it.